Okay, tonight we're going to continue on with our lectures on trauma. The remainder of the semester we're going to talk about trauma, and your final exam will be mostly on trauma, so it'd behoove you to read the trauma chapters as well as the ITLS ones, which are pretty close to the ones for the book. They're just more the absolute what you need to know versus the good to know, but the good to know is just as important, it's just as mandatory. So I keep up with both of them. We're going to talk about burns. Burns are some of the most debilitating wounds that people get, not just from a physical point of view and a physiological point of view, but from a psychological point of view. Burns can be very debilitating. Burns can have a long time lasting effect, and burns have a high rate of morbidity and mortality associated with them due to infection and other things comes as a direct result of it. As you see here, you have a gentleman here who obviously has had some burns. You see some, burning to his face. You see redness. You see charred skin and things like that. We remember from our basic class, we have our first degree, second degree, third degree burns, and also we have a fourth degree burn, which involves the bone. When you look at burns like this, we know that they're very, very painful. And when we see a type of burns, even first degree burns to the face, we need to check the nose, check the mouth for any type of soot, any type of contamination, because inhalation burns are some of the most devastating ones you can get. These are objectives, so we're going to talk about the skin, which we did last class through talking about the integumentary system. Talk about basic functions of the skin. We know the basic function of the skin is protection, thermoregulation, so forth and so on. We're going to talk about different types of burns, and we're going to talk about how to estimate the burn based on skin appearance, and also estimate the burn using the rule of nines. Also, we'll talk either within this lecture or the next lecture about the Parkland formula, which is used for fluid resuscitation needs within the first 24 hours post-burn. So these are just more we'll talk about all the different types of burns there are. We'll talk about carbon monoxide and how it causes hypoxia. Remember, carbon monoxide binds to the hemoglobin with the same affinity as oxygen. Therefore, pulse oximetry is very inaccurate. You can have 100% reading on a severely hypoxic patient. So don't get too hung up with that pulse oximetry reading. Okay. So burns. One, obviously, is scene safety. You need to have your body substance isolation, your universal precautions on. Scene safety is very important, especially if the burn came as a result of an explosion of a fire ignition source, anything like that. So I always want to do a scene size up. Is the person, needing to be rescued? Even though we see it on TV, you should never run inside of a burning building to rescue someone without appropriate attire. You may become the next victim. So we want to make sure that we're safe, and want to make sure that patients are being rescued by people who are trained to do the rescue. Multiple agents can cause burn injuries, and damage to skin is pretty similar on most of them, but we'll talk about all the different things. So keep in mind, you may not run on a whole lot of burns, but burns are very different. I took care of a burn this past summer. This person had one of those e-cigarettes that was in his pocket and was crawling under a house, and the e-cigarette somehow ignited in his pants pocket. And by the time he realized he's burning, tried to get out, he had already had second and third degree burns of his thighs and genitalia. So burns, can be very devastating. Functions of our skin, also known as the integumentary system, the biggest system in our body. It provides that mechanical barrier, so it protects us from foreign invaders. It helps us with thermal regulation. It's a sensory organ, so we can sense hot, we can sense cold, we can feel pain, things like that. When we burn through these layers and the nerves are burned, then that burn becomes painless, at least in that spot. Third degree burns tend to be very painless, but they do have very painful first and second degree around those. And temperature regulation. Our body, through use of sweat glands, have a way of cooling the body down, um, and through fat stores have a way of keeping us warm in the winter. So burn trauma, skin damage, you get direct injury from heat, or there could be chemical burns. Chemical burns are very devastating. It could be damage from inflammatory process. The sources of damage are thermal, so heat, electrical or electricity source, a chemical, could be any chemical, and radiation burns. And radiation burns are very devastating as well. And if we see here, we see a person who doesn't appear to be very much long for the future with all of his burns. It looks like a pretty significant chemical type burn. So burn classification, so we have superficial. Superficial is the same as a first degree burn, which is known as a sunburn essentially. Okay, they become very red, they get kind of weepy, and they hurt. Partial thickness, which is the second degree burn, are denoted by blistering. They tend to be pretty painful. Many of your top layers of your skin are affected. Your full thickness, which goes through all of the tissues essentially, where it has a very charred appearance to it, they tend not to be very painful at all as the burn has burned through the nerve endings. To measure the extent of burns, you have your rule of nines. They have the London Browder chart, and they have the rule of palm, or the Palmer surface. And the Palmer surface, just remember that the palm is 1% of body surface area. So you can always do that as a measurement. So we'll talk about that here shortly. So burn deaths, we have superficial, as we see here, minor tissue damage, the epidermal layer, intense, painful, inflammatory response. The skin gets very red, gets very weepy. Treatment would be based on symptoms. We want to keep these people as comfortable as possible. They do make like water gel dressings. We want to kind of cool the burn as much as possible. You should never put anything petroleum based on burns. So no Vaseline, nothing like that. Generally you want to use dry sterile dressings. You can initially do moist dressings and follow them up with dry. But generally people are using dry dressings most of the time. Treatment, start an IV. Remember, if people get these burns, they do have your skin holds in a lot of your body volume, so you can lose a lot of body water through burns. So you want to start an IV of normal saline or lactated ringers. You want to give boluses as needed at 20 mLs or 20 cc's per kilo. You want to give pain medicine as needed. You can give 2 to 4 milligrams of morphine, which is the maximum vasodilatory property of morphine, up to 10, and there's generally 2 milligrams every 5 minutes thereafter. Or we can consider giving fentanyl, which is generally 100 mics, which is when I administer it personally. I start at 50 mics and work my way up with it. And if you have somebody that's like small body area, a small body type, you start at 12, start at 25 milligrams. Nothing says you have to hit them with 100 like you see that's done out there sometimes. So just be kind of judicious in how you do your pain medicine. Partial thickness burns are denoted by the blistering. There's not normally scarring with this. The depth is variable. Management, we want to cool the burn, we want to cover it. We want to use dry, clean dressings. Okay, so we don't want to pop blisters on the dry, clean dressings. Antibiotic creams are very rarely ever recommended in the pre-hospital environment. They're normally recommended after they get debrided at a burn center. And remember our transport decisions. Patients with burns are best treated at burn centers, especially if you have an injury like this. And this, you might look at this and be like, well, we got second-degree burns on a hand, a lot of blistering. But remember, it can be very limiting as far as use of the hand goes. And when we talk about life or limb injury, significant burns of the hand is definitely a criteria for going to a trauma center or a burn center. So don't think that just because one body part is burned that it's an insignificant event. It could be very significant. Full thickness, we normally see a char, the leather-like eschar, Eschar is that charred tissue. The procedure for opening up those areas to prevent compartment syndrome is what's called an escharotomy, and that's used by taking a scalpel and incising the leather-like eschar to allow for the skin to expand, improving circulation to the extremity, or allowing for the chest to rise and fall. Escharotomies are very seldomly done in a pre-hospital environment, and then only done in systems where they've been trained to do them. So, the escharotomy is generally used on extremities. Also, it's primarily used for circumferential or around the chest burns, where the chest doesn't expand. And then the escharotomy is generally done, every so often on the rib areas to allow for chest expansion. Don't confuse escharotomy with a fasciotomy. We talked about fasciotomies a little bit on skin trauma. Fasciotomy is cutting through the deep tissues down to the muscles, the fascia. Escharotomy is cutting through burnt tissue, and that's only done on third-degree burns. Okay, so we look at the burn depth characteristics, how we look at this. First degree might be a sunburn, someone's laid out, might be a flash burn. A flash burn is having a very quick exposure to a hot source. The skin gets red. It may be dry with no blisters. It may start getting a little bit moist, though, when you get some weeping. Painful, takes 3 to 6 days to heal. Partial thickness, you get this from hot liquids generally. Very hot flashes, or not hot flashes to be consumed, but flashes of much like the flash burn have more prolonged exposure or exposure to direct flame. The skin gets very mottled, real wet appearing, and is red. Weeping blisters is very painful, and this takes 2 to 4 weeks, depending on depth, to heal from. Then we have our full thickness, which is our third-degree burns. These happen a lot of times with chemicals. Electricity, remember, our bodies are made up of water, and electricity takes the path of least resistance, and water is a super conduit for the transmission of electricity from one source to the ground. Hot metals come in contact with something that's very hot. They take on this real white or this real charred, skin. The skin gets really like they said, parchment-like, like real thin, like a paper-like, feel. The skin's very dry. Thrombosed or large blood vessels, anesthetic, with peripheral pain. So these, they don't hurt very much at all, but they will hurt around the actual burn. So you may have full thickness with first and second around there. These are normally very debilitating and require long healing processes, requiring multiple skin grafts and multiple surgeries. And like I said, the secondary problem with trauma is infection, which tends to be a big deal. Also, hypothermia on these burns. Remember, our bodies are a protective thing, so these patients can become hypothermic if not careful. Okay, burn depth. When we look at these here, we see the second-degree burn here. We also see here, we see some second-degree. We see here, we see some first, and we see some full thickness burns and whatnot. Always need to, keep in mind that burns, like I said, are very debilitating. Also, they're really hard on the responder to keep an eye on. We look at this one and we'll see, some charring, and we see different degrees of burns. Whereas here we tend to see, looks like it's just a severe sunburn type thing. But we also note some blisters, some weeping skin, so forth and so on. So definitely second degree with first degree around it. Okay, you have scald burns. One of the things to keep in mind, scald burns are when you put a part of your body or your whole body in something that's very hot and then pull yourself out of it. These happen, when that happens. It could happen from pouring hot coffee on you. It could happen from any, super hot source. One thing to think of when you look at this picture here, you want to look at here what they call like the line of demarcation, which you see the line here where the burn stops. Okay, this is a child is either put down in the water on their feet, but if you notice like the bottoms, if you barely see like the bottom of their toes, there's no burns there. So when you see something like that, you really need to suspect possible child abuse, because when the child's legs are held against like the bottom of a bathtub, where the feet are touching the bottom, doesn't get much heat. But the heat from the boiling water or the super hot water is actually causing all this damage. So that's one of the things you'll see, which is inconsistent injury pattern. We'll see burns here with that line of demarcation, and then we'll see little to no burns here. Is it child abuse every single time? Well, not necessarily, but you do need to be suspicious if the injury doesn't match the mechanism, and you want to be very cognizant of things that just don't go together. So, burn death, progression, inflammatory response. This keeps going for on a couple days. The body holds a lot of heat. You'll end up with severe fluid loss, goes on hours for days. Sepsis goes on. Remember, the body's job is to fight off infection, and we lose the ability to do that with severe burns. As the burn gets deeper and deeper, it reduces circulation, so you may have issues with peripheral pulses with that. Management, if you have reduced circulation, these patients need to go to a level 1 trauma center, level 2 trauma center, or by far, if you have availability within close resources, a burn center. Burn centers are very, very useful. You should know where your burn centers are in your area. Your management is to limit progression depth, so you want to take the heat out. So you want to, put dry sterile dressings on it, maybe put some cool packs on it. If you have to initially put some wet clean dressings over the top of it, or the water gel dressings that drape over the top of people, or over to the extremities. A lot of fire service carries the water gel dressings, and you want to limit it, get the heat down and limit it extent. But generally, dry, sterile dressings are the way to go. Okay, you have the Rule 9s, and Rule 9s is something that I definitely commit to memory. Your infant, your child, and your adult. Very, very important. You need to definitely, you'll need to know this for your final. And this is nothing new. You should have been taught this in your EMT basic class. It's nothing new. However, it's something that's not used every day, so a refresher is definitely in order. But when you look at the chest you have 9 front, 9 back. So total of 18. Abdomen, 9 front, 9 back. Your leg, same difference. If you look at the groin is 1%. So is the palm of the patient's hand. So you want to check that. Pediatrics goes as such, and infants is as such. But I'd definitely be familiar with the Rule of 9s. The London Browder chart is very, very specific, and it's not something you need to memorize per se, but it is something used by ERs and burn centers, and this gives you the exact extent of burns. So it breaks it down by body part. So if you have a left foot that's burnt, depending on the years, so say an adult, 1 foot would be 3.5% body surface area. So, that's how this chart works. So it breaks it down by age and years, and also by body part. And then when you add up all these for the total, it gives you the total percentage of body surface area burned. The palm method. The palm is 1% body surface area. The palm method, it's easy to use and easy to remember. Okay, this is the important thing if you're taking notes here. To estimate the burn area, use the patient's hand. Do not use your own hand. Your hand would not equate to 1% of that patient's body surface area. It's the patient's own hand would be more appropriate. No, not more appropriate. It's the correct way to do it. Okay, and you want to use the palm, including the fingers. So it's the full palmar surface of the hand. Okay, but remember, it's not your palm, it's the patient's. Very, very important. Okay, burn assessment. ITLS, we talked about Zone Trauma Life Survey, primary, secondary surveys are essentially identical to your primary and secondary surveys we do in the National Registry testing sheets we did in the assessment chapters. So don't get too hung up on ITLS primary and secondary because they're the same. Specialty resources. Does this person need rescue? Does this person need aeromedical resources? Does this person, need fire departments? Does this person need extrication? Okay. The person needs to be safely removed from the source, whether it be thermal, chemical, electrical, toxic byproducts like smoke. So you can have a chemical fire that's put out, but the smoke itself is very noxious and very toxic and very hot. So you could get a lot of burns to the airways as a secondary exposure. Okay. So the big goal is to stop the burning process. So we want to get them out of that. So we want to limit burn progression. We want to cool the skin, clothing with water, sterile water, or saline 1 to 2 minutes, keep it flushed. We don't want to do a whole lot longer than that because you can induce hypothermia. You do want to also have dressings available. You want to remove the clothing if at all possible, especially if you're dealing with a contaminant or a hazardous material. You want to remove the clothing, and including, don't forget to remove their boots. I've seen cases over the years where people have flushed a chemical by adding water to it. You should never add water to a dry chemical, and actually activating the chemical, producing a heat source, and actually flushing it down into their shoes where they had burns of their feet. So, you need to be able to, like I said, keep in mind, sterile water, is a good thing to limit burn progression. But if you have any dry chemicals should be dusted off that patient. They should be removed from their clothes, and prior to any type of irrigation whatsoever. Sterile sheets are not necessarily necessary. They're on the ambulance. But if they're part of a burn kit, great. I don't believe the state of Illinois or a lot of state requires them anymore, but most ambulances do have them. And these are those blue sheets that stretch over the stretcher. We want to maintain body temperature, prevent hypothermia. Someone can get a significant burn and get hypothermic in 98-degree weather. So we want to keep in mind that. Remove wet clothing. Remove all jewelry around that burn area, because you may not get the opportunity to remove it later. And if you don't know how to remove it, try to see if someone close by you does know how. With a lot of the body piercings and whatnot, they have different mechanisms for taking them out. I remember once years ago when I was working in the emergency room, a patient was brought into the emergency department with her head covered up, and what happened was she was putting a bunch of hair product in her hair, went to light a cigarette and lit her head on fire. And when they brought her in, she had second and third degree burns of her face and head, but she had these big gauges in her ears and had tongue piercings and all this stuff, which at the time, we're talking almost 20 years ago, none of us were very familiar with stuff like that because they weren't as prevalent as they are today. But luckily, we were able to get a hold of, one of the local tattoo people, and they came in there and removed them for us. So that was definitely an educational experience. So that's one thing that'd be good to do too, is if you have a tattoo parlor or tattoo people in your area, or have people with lots of piercings that are near to you, talk to them and find out how those things come apart and how to remove them if need be. Okay, airway burns, very severe. When we look at this gentleman here, we see that his nose is singed, his lips are singed and charred, and look at his tongue, you see charred. Right there when you see that, that's a sign of inhalation burns. Burnt lungs through superheated inhalation of air, can cause major pulmonary edema. It can cause major heat damage to the lungs and really lead to gas exchange problems, because this person will be in a chemical type pulmonary edema or a pulmonary edema through the damaging of tissues. So this person here, you want to, you can give them humidified oxygen. These patients need to be intubated rapidly. or they may lose their airway, and the next line of treatment would be doing a needle or surgical cricothyrotomy on this person. If you're going to intubate someone who has suspected airway burns, you need to do it early. You need to use appropriate medications, and we'll talk about this in the fourth semester. We talk about rapid sequence intubation or rapid sequence induction or drug-assisted intubation, all the different terms for that. But you want to use proper medication, and you want to be able to be very gentle in your intubation approach so you don't induce further swelling. But you want to be ready with one ET tube the size you need, and a couple sizes smaller. Because when you view the glottic opening, if you can't get the tube to pass, you need to have someone hand you a smaller tube. So you should always have a couple tubes out and ready that is the size you need, plus one or two sizes smaller, just in case you can't get through the cords. One thing to keep in mind, which we haven't talked about rapid sequence intubation or rapid sequence drugs that much, but one of the most common drugs used, and it's falling out of favor somewhat, is succinylcholine or Inectine. It's a neuromuscular blockade medication. It's short-acting, lasts about 15 minutes, and will paralyze the whole body. It's important to remember on burn patients, burns are very painful. So if you give a paralytic just makes someone not able to move. It doesn't make them not remember what's going on. The person's brain is totally awake. They're totally able to feel pain. They just can't communicate that. Succinylcholine also is contraindicated in the burn patient. Important thing to remember. So succinylcholine, not indicated. And the reason it's not indicated is because succinylcholine will cause spilling of potassium, which will make your patients hyperkalemic. So, the last thing you want is your patients start having dysrhythmias and other problems due to hyperkalemia. So we want to really watch that. So with succinylcholine, so no sucks with burns. You don't want to do it. If you go to get them intubated, you want to get it as soon as possible. You want to use capnography. And you want to be very careful once you put this person on a ventilator. In the fourth semester, we'll talk about ventilator and ventilator settings. But you want to really watch your tidal volume, because if a person has lungs full of fluid, you do want to use, some increased tidal volume to a point. And you want to use some PEEP. But if you suspect major pulmonary damage, you can also be very careful by giving a larger tidal volume than the patient needs, because you can actually cause the lungs to burst. So, and that would be definitely a bad thing. Hoarse voice, so persistent cough. They may hear wheezing or crackles. Remember, wheezing is indicative of bronchoconstriction. Crackles is indicative of pulmonary edema. So you can go ahead and give these people albuterol. You can give them dual neb, things like that. Or if you don't have those drugs available to you, which you should on an ALS ambulance or a BLS ambulance in the system, you can still give humidified oxygen through putting saline in a nebulizer or through a humidifier if your system has those. Critical problems, mechanism. So is this person in a confined space or a closed space? Can you get to this person safely, or do you need specialized rescue? Is this an electrical burn issue? Electrical burns, are very, very devastating. Chemical exposure. What will hurt them will hurt you. As a result of being burned or electrocuted, did they fall from a significant height? Did they have major blunt force trauma? And remember, people get burned sometimes as a result of medical conditions. An example that I've used for years is I had a gentleman one time who was COPD. He was wore oxygen all the time, and he was cooking beans on the stove. His oxygen tubing got too close to the burn source. It melted the oxygen tubing, and oxygen is highly flammable, so it went up the nasal cannula and lit his face on fire, lit his nose on fire, and the guy ended up dying as a result of that burn injury. So very, very important. So always suspect underlying causes as a result to people, could have strokes while they're, doing this and that. Had a lady not that long ago who was she had to stand on a stool, and she had some weakness on one side because she had a previous stroke, and the stool went out underneath her, and she fell onto the open flat top stove and couldn't get her body off of there, and sat there and burned and burned and burned until someone heard her and came in and pulled her off to the floor. And she had already burnt through one arm where the arm was partially amputated. She burnt an entire breast, burnt away, major burns on her abdomen. Um, she ended up surviving, but after long, long courses of rehabilitation and skin grafting. We're going to go on, being that this lecture is a little bit longer, and we're going to stop recording at this time, and we'll start recording another link here shortly.